So hello, thanks for having me again. And my name is Thor Halfdanarson. I'm a medical oncologist and professor of oncology at the Mayo Clinic and one of the several neuroendocrine tumor specialists at the Mayo. And my talk today is on the latest in systemic treatments and consideration for treatment sequencing in neuroendocrine tumors, advanced neuroendocrine tumors. So these are my disclosures. And let's just get into the basics before we start talking about individual treatment options. Probably the most important thing is that not everyone needs therapy. For example, some of the early stomach and pancreatic NETs are best observed, and we just need to make sure we follow patients appropriately. So if you have someone who has symptoms, then we may have to start therapy earlier than that. And some patients with advanced or metastatic disease can actually be observed without any treatment. But if you have a poorly differentiated neuroendocrine carcinoma, something that's a little bit more aggressive, something I won't talk about this talk, then you have to start much sooner than in most patients with well-differentiated NETs. So again, we have to look at every patient individually. So number one, we need to know if there are symptoms. If there are symptoms of tumor bulk or functional syndrome like carcinoid syndrome or a pancreatic neuroendocrine tumor causing a hormonal syndrome. And if that's the case, then we should typically initiate therapy early, typically with a somatostatin analog, but also with regional therapy. And what I mean with regional therapy is resection or surgery or embolization or ablation, something that essentially destroys the tumor cells and stops them from producing those hormones. And another thing that sometimes is forgotten is to consider the importance of other medical conditions that the patients may already have. And as an example, if you have a poorly controlled diabetes, then treatment with everolimus, or even treatment sometimes with the somatostatin analog like octreotide, lanreotide can be challenging. If you have poorly controlled hypertension or high blood pressure, then some of the newer drugs like sunitinib and cabozantinib can be challenging. And if you have really poor kidney function, which is not that uncommon in patients with NETs, then we have to be really careful with PRRT. I'm not saying it can't be done, but we just have to be careful. And then also be mindful of the toxicity of the treatment. And it's helpful to know if the treatment is going to positively affect the quality of life, but not all treatments do. And then be aware of financial toxicity. Some of these treatments can be very, very costly, especially some of these oral medications. So moving on to a few other principles of therapy. So one of the goals would be to treat growing tumors. Another goal would be to treat troublesome symptoms, be that from pain or hormonal symptoms. And sometimes you're trying to treat both. Sometimes not so much with systemic therapy. You're actually going in with curative intent. So let's say you're trying to shrink a tumor in the pancreas to allow for resection to be done. So then we would call that curative intent therapy. That's not commonly used for neuroendocrine tumors, but occasionally. And then we have to pick a treatment that fits the goals of the therapy. So in general, and this is how I think of this, select the least toxic treatment that achieves the goals. And there can be more than one choice there. And then also be mindful that not all treatment has been shown to improve symptoms or improve quality of life or even prolong life for that matter. And if there are any doubts about the roles of individual medical disciplines, let's say like surgery or interventional radiology with embolization or someone else, you present the case at tumor board. Tumor boards are incredibly important for planning therapy for patients with relatively complex cases, especially before planning any intervention like surgery. So how do we select the initial therapy? So some of those things we talked about before, but before you start, make sure you know the tumor grade and stage. Make sure you know the location of the primary tumor, because that will dictate some of the treatment choices. For example, look at the pancreatic neuroendocrine tumors, where we might pick different treatments than we would do for small bowel NETs. And then, is the somatostatin receptor present on the surface of the tumor cells? Have we done a dotatate or a gallium or a copper PET to look at that? And obviously be mindful of the goals and wishes of the patient. And then for most patients with somatostatin receptor expression, somatostatin analogs like octreotide and lanreotide are a good initial choice, especially if there are functional tumors that express somatostatin receptor as seen on a PET scan. So the SSAs can be really effective in controlling functional syndromes, but they don't really shrink the tumors much. but sometimes can keep tumors from growing, sometimes even for years. I've seen occasional patients go beyond 5 years on injections without any tumor growth. And they tend to be well tolerated, and the side effects from SSAs tend to be fairly easily managed, but you just have to be aware of those side effects. And then if there are no activity on the PET scan, no somatostatin receptors, well, you got to come up with a different plan, because if your target is not there, the treatment is not going to work. In terms of somatostatin analogs, we have two of them. We have long-acting octreotide and long-acting lanreotide, and to look at them as essentially identical drugs. But the octreotide is a little harder to inject. It has to go deep into the muscle in the gluteal region or in the buttocks region there, and it's easier said than done. So we know from studies in the past that up to 50% of injections may be incorrectly administered, and then the octreotide is sitting in the fatty tissue, not in the muscle, and may not go into the system as easily as it should. So if you look at these two trials, so the first one was the PROMED study, which looked at octreotide versus placebo. Here, patients who were on octreotide went much further than those on placebo, so 14.3 months versus 6 months on those who were on placebo. And another study called the CLARINET looked at lanreotide, and you can see there that the patients on placebo, they actually went 18 months, because these were generally slower growing tumors versus almost 33 months for those on lanreotide. So there's no question that octreotide and lanreotide slowed tumor growth. But interestingly, in the PROMED study, if you look at the median overall survival or the life expectancy of the patients, there was no difference. So it doesn't seem to matter whether you start early or later in terms of life expectancy. You're going to get the same results. I think the same will probably apply for lanreotide. So how do we sequence therapy beyond the first-line somatostatin analog therapy? Well, the problem here is we don't have a lot of trials. We do have some ongoing trials I'll talk to you about in a little bit. So it's very important, if there is a trial, to consider enrolling on those trials, because that's really the only way we can move this field forward. If we don't do well-done clinical trials, then we're not going to know what the ideal sequence is. So as with starting therapy, all the usual conditions apply. So we have to think about the goals of the therapy, the presence of symptoms, comorbidities, and patient goals and wishes. And then the question that sometimes comes up, and I don't think I have the answer to this, is that does the sequence even matter in the great scheme of things in terms of life expectancy? So we don't really have good studies that show that sequencing affects overall survival. I think actually it may. But then some have said, as long as you ultimately get all of the available options, does it really matter that much? Moving on here to this figure here. So this is from a paper that was published last year. This is just looking at the spectrum of therapy for patients with neuroendocrine tumors. So on the far left side, on the green part of the arrow, you can see the lower grade tumors, low disease burden, so few metastases that are not moving, and observation is certainly reasonable there. And then as you move over to the right side, as that arrow or the line there gets more red, that means more aggressive tumors, higher proliferative rate, higher Ki-67 index, where we have to do something different. And that could be anywhere from somatostatin analog therapy to kinase inhibitors, everolimus, PRRT, and for the most aggressive tumors, we might actually be looking at intravenous or IV chemotherapy. So let's talk about some of the newer studies that have come out. So you may have heard of this CABINET trial. So in this study, which was not looking at sequencing, but was looking at the activity of cabozantinib, which is one of those kinase inhibitors in patients with neuroendocrine tumors, both GI, lung, and actually pancreatic neuroendocrine tumors too, who had tumor growth on at least one FDA-approved therapy, not counting the SSA. So these were patients who some had quite heavily pretreated disease and now had progressive malignancy, and they were randomized to either cabozantinib or placebo. And the primary endpoint there was what's called progression-free survival. So essentially the time it takes tumors to grow, or also if the patients die, that counts as an endpoint too. And at progression, so tumor growth, the patients had the option to cross over to cabozantinib if they were on the placebo. And we didn't know, and the patients didn't know if they were on placebo or not. So here are the results. So these were presented late last year at a meeting in Europe. And for the extrapancreatic neuroendocrine, which are mostly small bowel and lung neuroendocrine, you could see that the cabozantinib was definitely more effective than placebo, 8.3 versus 3.2 months. And for the pancreatic NETs, even more prominent, 11.4 versus 3 months. Lenvatinib is a similar drug, and I won't dwell on this, but I wanted to show this study of 111 patients, half of them with pancreatic neurotumors, half of them with GI neurotumors. And in this study, there was no placebo. Everyone got lenvatinib, and the patients with pancreatic NETs were more likely to respond in terms of significant tumor shrinkage. 44% of them had significant tumor shrinkage, while only 16% of those with GI or small bowel NETs had significant tumor shrinkage. But if you look at the progression-free survival, it wasn't really that different in these tumor groups. So even if the response rates were much higher in pancreatic NETs, the progression-free survival was actually the same. Lenvatinib is not approved for NETs. I won't dwell on this because this is not a drug we use in the US, but this is actually one of the very, very few sequencing studies out there called the Sector study, comparing everolimus with a chemotherapy called streptozotocin. So here you could either start with everolimus or Afinitor and then go on to streptozotocin on progression, or you could do it the other way around, start with streptozotocin and then go on everolimus. And they looked at if the sequencing mattered. Then apparently, at least for the first progression, doesn't really matter. So the outcomes there in terms of progression-free survival were almost identical and not statistically different. So where this goes in the future is hard to say. So with the drug, we don't really use much in the US, but it just shows that even if you have a sequencing study like this was, there is no guarantee that study is necessarily going to inform us one way or the other. It might come out as a wash in this study where both options are good. So this is not a sequencing study. This is a study that compared in patients with pancreatic neurotumors, either a combination of capecitabine and temozolomide with temozolomide alone. So looking at whether the addition of capecitabine improved outcomes. And then indeed it did. So if you look here at the progression-free survival, it was longer in the patients who got capecitabine, almost 2 years compared to 15 months. But when it came to the overall survival, there wasn't that much difference. There is numerical difference of 54 months in those who got temozolomide versus almost 59 months in those who got capecitabine and temozolomide, but this was not statistically significant. And in terms of the tumor shrinkage rate, it wasn't significant either, but you could see that the combination had a response rate of almost 40% compared to 34% in temozolomide alone. So here, it didn't seem to affect the overall survival that much. So the take-home message here is that the PFS is better with capecitabine, but not significant overall survival rate. So moving on to another study, this is in pancreatic NETs, a study done in France comparing sunitinib with PRRT with lutetium-177, also known as Lutathera. So in this study, 84 patients were randomized to either sunitinib versus Lutathera or lutetium-177 PRRT. And here we could see that the PRRT was more effective. The median progression-free survival here was almost 21 months in the PRRT group versus 11 months the sunitinib group. And if you look at those who did not have progression on 12 months, 80% of those in the PRRT group did not have a progression at 12 months from starting therapy, but for only 42% in the sunitinib group. So clearly in this cohort of patients with pancreatic NETs, PRRT is more effective. But will it change the life expectancy at the end of the day? We just do not know. Well, this study tries to address this. This is probably one of the most interesting, what we call retrospective studies I've seen in years. So this was done in Italy, a little over 500 patients from 25 different Italian centers, half of them with pancreatic NETs, 80% of them with liver metastases, all progressing on somatostatin analog therapy. And this was not a randomized study. They just looked to see what happened to the patients who got PRRT after progression on SSA versus those who got chemotherapy or targeted therapy, which we can see is labeled there as CT or TT. So CT for chemotherapy, TT for targeted therapy. And what they found there is that the PFS was definitely better with PRRT. That's the progression-free survival, 2.2 years versus 0.6 years. But if you look at the life expectancy, the overall survival in those two groups, there was almost no difference. And in fact, it wasn't even statistically significant. But there are two take-home messages from this. It doesn't seem like the sequencing, at least in this study, mattered that much. And probably everyone who got chemotherapy and targeted therapy ultimately got PRRT. And the other take-home message there is that in this group of patients with metastatic disease progressing on somatostatin analog therapy, the life expectancy was more than 11 years for both groups, which I think is very, very remarkable. And it's only going to get better. We're only going to get better treatments. So we have a few ongoing trials. I'll go quickly through these, but do consider these trials if they are available to you. So there is this trial comparing PRRT with CAPTEM in patients with pancreatic neuroendocrine. So this study is open, led by my colleague at Mayo, Dr. Tim Hopday. So definitely something worth considering. If you have someone with grade 2 or grade 3 neuroendocrine tumors, we have the COMPOSE trial we have open. COMPETE was a trial comparing PRRT with everolimus. That trial is now done, but hasn't been reported yet. COMPOSE is still open, comparing 6 cycles of PRRT to either CAPTEM, FOLFOX, or everolimus. So that study is still ongoing. So do keep that in mind. We now have a PRRT trial for patients with lung neuroendocrine tumors or pulmonary carcinoids. So looking at PRRT versus everolimus. So this study is open as well. And that has crossover at progression. If you end up on the everolimus arm, you can cross over to PRRT at a later date. This is a really important study to get done because we have so little quality data on therapy in patients with lung NETs. So just to wrap up, so think about it this way. So you have multiple different treatment options. They each add a number of months or years to your life, and you have all of these options. And if you put them all together, it's going to be like the sum of the parts added together. But what we're actually seeing is that if you have these treatment options, or what are sometimes called the treatment cards, and you just play them really wisely when you need to, your overall life expectancy or survival is probably going to be much greater than if you just sum up the individual benefits of each drug. It's not so much about what each drug or combination contributes, it's just the way you sort of play it. When you really have to, you play that card, if you use the card analogy. So in the last few slides, or a couple of slides, I'm just going to summarize how I think of small bowel neuroendocrine tumors, treating advanced small bowel neuroendocrine tumors. So the first question is treatment indicated? Well, if it's not, you just observe and do scans. Well, if treatment is indicated, the somatostatin analog is usually a good start. Now we may consider upfront PRRT for higher grade tumors as per the NET-2 trial, which was presented in January. Well, after that, you have the PRRT and the everolimus as approved options, although everolimus may have a little less activity in patients with carcinoid syndrome. Well, if you got PRRT up front, you're not going to give that again, or at least not immediately. So you would maybe go with everolimus unless you had the clinical trial. And then beyond that, you have the kinase inhibitors, the cabozantinib. There are a few others that haven't been, none of them actually have been approved yet. Or you can consider retreatment with PRRT, either on a clinical trial, like one of the alpha particle trials, or what's called NET retreat, which is looking at retreatment with the Lutathera, interferon, chemotherapy, and trials. And then at any time in the disease course, sometimes you may be in a situation where there's a localized tumor progression, and something like embolization or surgery might actually be an option. And keep trials in mind at any point in time. Well, how do we think about this with pancreatic NETs? So consider resection or surgery whenever you can, embolization whenever you can. But if you can't do any of that, then you have someone with advanced pancreatic NET and treatment is indicated. Well, you should ask yourself, do I need to debulk things? Do I need to make things smaller to improve symptoms? And if you do, consider something like CAPTEM. This is all for pancreatic NETs. Well, now we could actually think of PRRT, at least for the higher grade tumors, based on the results of the NET-2 trial. Well, if you don't need to shrink things, mainly to keep things stable and control symptoms, think of somatostatin analogs. Well, if you need to both shrink and control a functional syndrome, combine CAPTEM and somatostatin analogs. or possibly consider upfront PRRT, which I think is something we should be increasingly considering now. Well, beyond that, if you have progression on one of those treatments there, well, if you didn't get Kipton before, you can certainly use it now. If you haven't had PRRT, you can use it now. If you have never had everolimus, you could use it now. If you have never had a kinase inhibitor like sunitinib and possibly cabozantinib sometime soon, you can use it then. And then you can look at clinical trials. Or if embolization or surgery is appropriate at that time, based on tumor board discussion, you could consider that. Well, if there is a functional syndrome, you continue the somatostatin analog. If there is tumor growth again, well, then we sort of rotate through the options. You look at what has been given before. Sometimes you can actually go back to it, like PRRT, or you look at what has never been given and you say, well, I never gave everolimus. Maybe now it's time to give everolimus. So we have all of these options. And honestly, I don't think the sequencing at the end of the day matters all that much. But for us to know, we really need to do the appropriate trials. So that pretty much takes me to the end of the talk. Thank you.